Welcome everyone to today's webinar with the Accountable Care Learning Collaborative. My name is Scott Hammer and I'm from Levitt Partners, and I'll be moderating today's call on bundled payments. We're excited about today's presentation and the opportunity to explore the Medicare bundled payment programs, BPCI and CJR, and how they will impact and are currently impacting providers. We're grateful to have two experts joining us on the call, and we're looking forward to their presentations on bundled payments and understanding the influence it has had as well as will have on their respective organizations. With CJR beginning on April 1st and mandatory bundled payments affecting approximately 800 hospitals and 67 locations, we'll have an opportunity to learn how bundled care can potentially transform healthcare. Just a few housekeeping items I wanted to cover before we get started. To minimize feedback, please mute your line. If you are dialed in, please use your phone's mute feature. If you are using your computer only, click the microphone icon. If you are using both a phone and a computer, it is best to select the telephone option under audio in the GoToWebinar window, then mute your phone. There will be several opportunities for questions, so please submit them using the questions box of the GoToWebinar window. Today's agenda will consist of the following items. We don't have any announcements or updates coming from the ACLC, so we'll just jump into our presentation. First, we'll hear from Jim Gera from Signature Medical Group, who will share his thoughts on the BPCI and CJR programs, and then he'll provide more depth into how we apologize for that little mishap that we had with our audio feature here, and we'll just jump into our presentations right now. Quickly, I'd like to do an introduction of Jim Gera. Jim is the Senior Vice President of Business Development for Signature Medical Group, a multi-specialty group in St. Louis, Kansas City, and rural Missouri. Signature has 63 orthopedists providing services in all orthopedic subspecialties, including total joint replacement, sports medicine, and pediatrics. Over the past 14+ years, Jim has worked in a variety of areas of healthcare, developing and managing physician group practices, outpatient facilities, and worked in development for managed care companies and Medicare Advantage and special needs plans. Most recently, Jim has focused on programs and opportunities within health reform and the Affordable Care Act, in particular with BPCI. So I'll turn this time over to Jim, and Jim, thanks so much for joining us, and the stage is now yours.
Oh, I think I just got unmuted. Hey, thanks a lot, Scott. I really appreciate it. Honored to actually be invited to present to everyone. We looked at the list of folks on here. It seems like a very well-informed, highly educated, and intelligent group of folks who've joined the webinar. So we're going to move. I'm going to move through some things fairly quickly, give you some of our experiences, and then turn it over to Diwen, and then hopefully get into a lot of questions. So as Scott alluded to, we're a multi-specialty physician group practice, about 165 docs. What we've been participating in the ACA and a lot of the programs that came out of the Innovation Center since it came out in 2011. So we've engaged with a couple ACOs here in the state of Missouri, worked on several other grant programs. I served as a chairperson on the Innovation Round 1 and 2, and then also the Navigator grants. And then our biggest participation really has been in the BPCI program, where we're actually an awardee convener. And you can hit the next one. You can go next slide, Scott. So right now, as a awardee convener, we convene for approximately 60 orthopedic groups across the country, comprised of probably about 15% of the orthopedics in the U.S. So you can see it's a wide disbursement of organizations and physicians we're working with. Next slide. You can go next slide. So we've got about 45,000 total joints a year, about 2,000 orthopedic physicians that we're working with. So a lot of the things I'm going to be talking about today and discussing are what we've experienced not only as a physician group participating in BPCI, but also as an awardee convener, and what we've seen as an impact of bundle payments on physician group practices. So just to start off, let me give you a bundle payment overview. I think you guys probably already know this. If we look at the history of bundle payments, they're not new. It's something that's been around for quarter of a century, especially with the ACE demonstration project. I think Medicare with Prometheus and ACE, they've both seen that there's a history of success in bundle payments, which obviously spurred the engagement with BPCI and then quickly turned into the engagement in CJR, which is really still just the very beginning. I think everyone who's involved in bundle payments at this point expects Medicare to continue to roll out new programs similar to CJR, either expanding the current program or actually, excuse me, or adding new episodes to that. So if we look at, real quick an anatomy of a bundle payment, I'm sure you guys know this, but to kind of give you a little breakdown, bundle payments really, it's a financial mechanism. It's a payment. It's a contractual arrangement. It covers a specific episode of care, so you have a specific time period, a specific type of care that's being managed, whether it's sepsis, pneumonia, whether it's an orthopedic episode for spinal fusion, for an upper joint replacement, for lower joint replacement. It covers a specific period. There's upside, there's downside. You're taking all of the different providers that normally bill and collect for those for services related to that particular episode, and you're linking them all into one single payment. That single payment is also linked to quality metrics. In general, there's really just two types of bundle payments. You could talk about a reference pricing, which would show similar, which could be similar for a bundle payment in that you'd have specific prices for certain areas of care. But essentially, bundle payments kind of roll into two different things. Retrospective bundle payments, it's a look back at the actual services. So all of the entities and providers that are engaged in a bundle payment, they bill and collect as they do normally. There's no adjustment or change in the revenue cycle. What the entity would do, in this case, under BPCI or CJR, what Medicare would do is they look back at what are our actual costs versus the targeted price for the period of time that we measured, a previous quarter or a previous year. it's really, we would consider it sort of a hybrid bundle. It's not really a true bundle. True bundle would be more along the lines of a prospective bundle payment, which is, okay, you're going to do a total hip or a total knee replacement. Here's all the services that are going to be covered inside of that therapy, the facility costs, the surgeon's fees, other costs associated with that. And you're going to receive a prospective payment up front, and essentially that provider is then responsible for managing those costs. So that's basically the anatomy. Why bundle payments? Why would we be looking at bundle payments? Go to the next slide. There's been a history of success with them. So, you know, with the ACE demonstration project, and I think some of the early findings in BPCI, it's our belief from our engagement with CMMI that they believe that it's a successful way to manage an episode of care and to reimburse providers for managing that episode of care. The other thing I think we look at, we're involved in a couple different ACOs and looking at the difference in our experience with ACO models and with bundle payments. It's a little bit easier. I'm not going to say it's easy, but it's a little bit easier to get your hands around this one specific moment in time where you can manage something, right? So there's someone is getting a surgery to have a total hip replaced. You can in a period of time, a 4-month, 5-month period, to really focus in on that specific episode versus the challenges of dealing with a population of 10, 15, or 20,000 patients within your ACO that have a variety of different conditions that they're experiencing. So, you know, how do these bundle payments fit into the value-based evolution? And this is really my own personal view, is that, you know, you've got bundle payments, which is the financial mechanism, and then you really have the episode of care, which is the care management, how you think about it from a clinical and care pathway sense, is you think about the episode of care. So, you know, looking at how does that fit into what's going to happen in the population health environment is really what we believe is that, you know, for specialists or even for doctors, even like OBGYNs who are looking at managing a pregnancy, that's a specific episode they can get their hands around, they can focus on, and they can set up specific care pathways that have an impact in that moment in time. So we think that it's something that fits into an ACO or a shared savings model with primary care and allows specialists or any of those other providers that are focused on a particular episode to link in with a population health model. So let me give you a quick little background on BPCI. You guys probably already know it's been going on for quite a while. Funding opportunity was announced, released in fall of 2011. That's when we originally began our engagement with CMMI around this. Participants, whether awardees or episode initiators, began moving into phase 2, which was the risk period. They moved into phase 2 starting in Q4 of 13, really through Q4 of 15, where after Q4 of 15, no new additional episodes could be added. There were 48 DRGs eligible, so pretty much all types of episodes that were you know, that are done on an inpatient level could be included. So in BPCI, you're only talking about inpatient. You're not talking about anything that's done outpatient. We're not talking about outpatient joints or any other procedures like that. We are only talking about procedures that happen inside of the hospital. CMS released 4 models initially. 1, 2, 3, 4. 1, very little participation, primarily from New Jersey. Model 4, I think there's only about 8 hospitals that are still participating in Model 4 as a prospective system. A lot of infrastructure and logistical issues created, you know, that occurred, some challenges with that occurred that limited the ability to implement that model effectively. Majority of the participants are in Model 2 and Model 3. And as you can see from the BPCI participation, there's been quite a few, if you go to the next slide, there's been quite a few participants inside of this actual initiative. And I think one of the most interesting aspects to this BPCI initiative has been the number of physician group practices that have actually engaged. It's almost equal to the number of hospitals. That was very surprising for CMS that they actually had so many physician group practices engaged in this initiative. So now to give the background on CJR, our new program that's moved out. Yeah, and that last slide just kind of showing that how much we're actually engaged in this. So CJR overview, comprehensive care for joint replacement model. Again, a retrospective bundled payment for lower joint extremity replacements. It's just DRGs 469, 470. Why did Medicare pick lower joints? Really an area with high variation, high cost, and an ability for physicians and hospitals to really impact those variations in cost through better care redesign and improved standardized care pathways. It's something that we've seen in our participation in BPCI, and so we easily understand why Medicare looked at this being the first episode to make as a mandatory bundle payment across the country. 5-year program that starts April 1st. It's affecting 67 MSAs, about 800 plus hospitals. The hospital bears the financial risk and reward. It's a blended target pricing. We could have an entire hour webinar on this entire model, on the entire CJR model, but my assumption is quite a few of you are fairly versed in this at this moment in time. The couple things I did want to point out, because we're on quite a few webinars and get quite a few calls about hospital or physician group, some of the CJR confusion that is going on out there. And this is because of questions we get fairly frequently. We hear this very often. Hey, we don't really have to worry about, starting a program and getting a bundle payment program, an episode of care program started because our first year is free. We're not incurring any losses. Well, yes and no. Your first year is actually 6 months. So starting at the end of September and the beginning of October, those episodes that are done within the hospital for DRG 469 or 470, they're actually going to be counted in your second year. And the reason being for that is the episodes are counted in BPCI. The episode is essentially associated with a year or a quarter based on the start date of that episode, so based on when the surgery was actually performed in the hospital. In CJR, the episode is assigned based on the end date of an episode. So if you think about, you've got a patient who gets a total hip done on October 1st, they stay in the hospital for 2 days, they get discharged on October 3rd, October 4th. That patient then has 90 days within the episode, and so they're going to be bumping up against December 31st and whether or not they're actually in the first year or in the second year. Next thing we hear fairly frequently, stop loss or the stop gain cap. We're capped on our losses. So if we had a $500,000 loss, we only pay 5% of that. No, that's actually completely wrong. You're capped on your aggregate spend. So as you see from the math here, you do 350 episodes. You got a target price around $25,000. Your loss cap is $437,000. I can tell you it's not very difficult for an organization to not make any efforts and to not get engaged in care redesign and making changes, and for them to actually lose $400,000 or more, especially within a year's period of time. Another assumption that we hear fairly frequently, this is only orthopedics. Hey, we've got a really good orthopedic service line. We feel like we've made a lot of improvements. We've negotiated our implants down more effectively. We've hired an outside consultant that helped us standardize our preference cards, whatever that may be. I can tell you in our experience of having done, I think, over 50,000 total joints, well, actually over 60,000 now, that's not the case. I mean, this is a very comprehensive program. You really have to look at it from a full biopsychosocial model of care that needs to be delivered to the patient. So it's not orthopedics only. One of the things I wanted to point out is in some markets you're going to have CJR, BPCI, and you have an ACO. And I think there's a lot of questions as to what the heck happens with that. The simple answer at this point is I don't know if anybody really knows. A lot of times with CMS, they're actually figuring out the problems that happen in these models, these demonstration programs. They're finding that out in real time as they go on, and then they try to make the adjustments in real time to correct those. We have a couple markets where this affects us. What I can tell you is in one of the markets where we participate in an ACO that has 12,000 lives, we have the 2 participating orthopedic groups that are in BPCI that are also on staff with multiple hospitals that are actually gearing up for CJR. What's happening now is it has dramatically increased the dialogue. So everyone is trying, all the providers, hospitals, SNFs, primary care, orthopedists, they're all trying to figure out how not to step on each other's toes. So it has increased the dialogue. That's the only thing we've seen happen so far. We know there'll probably be mix-ups, and hopefully CMS will correct that. So what's been the impact to us at Signature? So if we look at what's impacted us, physician alignment engagement. So our physicians, traditionally before, the orthopedist, they get the clinical indication for surgery. The doctor, has the patient go to the primary care, make sure that they're cleared for surgery. Heart and lungs are okay, so there's not going to be a significant adverse outcome on the OR table. So the patient should be good to go. Physician does the surgery, follow-up within the hospital. They get discharged, follow-up anywhere between 2 to 3 weeks later, some recommendations by the orthopedist, and that's kind of about it. The big change has been looking at a much more comprehensive care pathway and care program, which leads into our care redesign. What we've been involved in, not only within St. Louis and Kansas City, but across the country in the 60 other cities we work in, is setting up and defining standardized care pathways. So from pre-op, acute, through post-op, there's a defined care plan for each individual patient. So you have individualized care plans for patients that also align with some standardized overall care pathways that the physicians have created based on best practices and evidence-based medicine. To really deliver that, we believe strongly in case management, especially case management that's delivered through a physician group, so you have the case manager embedded within the physician practice. So we've added new resources, not only RNs, but also social workers to deal with that now affects those who are involved in bundled payments. Much more engaged in care coordination, making sure that the transitions that happen between one setting to the next, making sure that discharge disposition is in the best interest of the patient for the best potential outcome, and not just what has been done prior to, for the past several years. Looking at acute opportunities, again, standardization and adherence. It's not uncommon for preference cards that have been set up by one physician 10 years ago, and those same preference cards are being utilized today. There haven't been major changes, and sometimes what ends up happening, especially in the acute setting, what we found is the supplies and the management and the setup is really done for sort of the worst case scenario or what potentially could happen, and not for what typically happens all the time. So, for example, we had one doctor we were working with on this. He as a standard opens up his staff. He goes in there, and the one nurses, she opens up 2 bags of cement every single time because that's been on his preference card for the last 10 years. Only about 10% of the time does he use 2 bags of cement. 90% of the time he just uses one, and one gets thrown away. So looking at creating standardization, moving over into the post-acute environment, big changes with that. Prior to our engagement in bundled payments, if we look at the post-acute care providers and the opportunities, next slide. If we look at that, prior to this, a lot of this was based on, individual preferences that might have been because of, personal relationships or ease of use or, the particular relationship, and not necessarily based on, always based on outcomes and actual results. So one of the things we've seen inside of our engagement in bundled payments is defining a post-acute care network, defining a preferred network of skilled nursing, of home health, having defined protocols and processes. So, if a patient is admitted in skilled nursing, who's going to see the patient, when is that patient going to be seen by the SNFist, what's the assessment that's actually done, if the patient has a UTI, how is that being addressed? Is it a treat-in-place option? Are they readmitted to the hospital? how do you address those things, and what are the protocols you put in place? There are a lot of options that are treated in place. I think when we look at the causes for readmissions, it varies from anywhere between 20 to 40% of the readmissions we see in groups participating can actually be avoided through better management of the patient, either preoperatively or postoperatively. Setting up score those relationships. Another underlooked thing as far as PAC network is developing the community resources that are available so that when a person wants to go home, a patient wants to go home, there actually is community resources either for transportation, Meals on Wheels, and other support that is available for that patient. Quality measures, right now 99% of our participating groups and physicians are hitting their quality performance targets. And for those groups, we have a majority of our groups are collecting patient satisfaction, 97% plus patient satisfaction. So the patients are loving the program that's been put in place and being administered. Technology, real quick, we kind of put this last because we see too often that there's maybe a big focus on technology being the first thing that you have to look at. And in our experience, it's kind of the last thing. It's like, if you decide to buy a house and you spend all your time at Home Depot looking at hammers and tools and not actually planning on what you need to do to build the house and how the house is laid out. I mean, the tools are a way to get the job done. The tools are not what actually gets the job done. So we look at technology real similarly, in a similar fashion. For us, we use a care management system that allows us to track and help manage the patient over their entire episode. And then also the analytical side. Prior, at the beginning of the program, we worked with outside vendors. We found that, unfortunately, most of the technology platforms that are out there are not adequate at effectively managing a bundle payment and getting true improvements. So most of what we've done the past year has had to develop internal systems to get better analysis, to get better real-time data, and better systems that our care managers who are managing these patients, systems that they can use to have a big impact on the patients. So what's the impact at us, Signature, as a convener? As a convener, we were a medical practice before, and we've hired a whole bunch of new people. So we've hired numerous individuals from Aetna and Blue Cross, Anthem, UHC, management with MCO backgrounds. Also, a lot of people with primary care backgrounds. We have quite a few, we call them regional case managers. Most of them have 25 plus years of experience. A lot of them with experience in population health for the past 20 years, even though they didn't call it population health. But doing risk management, especially with primary care doctors that are in Medicare Advantage risk arrangements. So a lot of new staff, hiring new certified case managers. All of the groups we work with have hired certified case managers to help manage their patients. Developing comprehensive care pathways, biopsychosocial care plans. I can't emphasize enough how much the psychosocial plays into orthopedic care. You have a 73-year-old patient. She's needs a hip replacement, and she happens to be the primary caregiver for her 78-year-old husband, and now she's going to go through this major surgery. What can we do to put plans in place to help continue the support of her husband in addition to her needs throughout her recovery? Our relationships with PAC providers and hospitals have changed. They've actually become closer in most instances, and we've developed more of a reciprocating relationship. And then technology development. We went from having a couple internal software developers to quadrupling that actually over the past 18 months because of our need to tailor and build technology that was allowing us to effectively impact and manage those patients. So on to last couple slides, the impact on your organization. From our experience, and this is our experience with working with the 60 orthopedic groups that have gone into the risk phase of BPCI. I'll start with leadership. it's a really big deal. I think people kind of make it a caveat that, well, of course we have the leadership, and of course we believe in volume to value, but I really cannot emphasize enough how absolutely critical it is from the C-levels down to the boots on the ground inside of the clinical setting. All those individuals have to understand and believe in whatever strategy you guys are implementing for a bundle payment. It's not the Ronco set it and forget it, so the CEO can't say, hey, I hired the service line person to do it, and that's their job. If that's the strategy, you're likely going to do pretty terrible. And if you're a CJR market or have a client in CJR, they're likely going to be paying a lot of money back to Medicare over the next 5 years. So leadership's really critical across the board. Physician leadership in CJR, very, very important, and it's key to have those guys involved. Care redesign, critical components. You want to be able to set up appropriate care management systems and processes, be effectively able to do care coordination, defining the care pathways, ideally preoperatively. Best case scenario is anywhere between 4 to 8 weeks prior to actual surgery, through the acute setting and into post-op. So you want to make sure that the communication, the care plans, all of that goes across the board and throughout the entire episode and is succinct and is all coordinated. One of the things I'll just put in here is that I think there's a general assumption, we had it initially, and we've heard this fairly frequently, is this general assumption that there's a lack of communication, that there's not enough communication with the patient. That's not necessarily true. What we find more often than not is actually there's an over-communication. So this abundance with communication actually leads to more fragmentation, because now you've got a physician, a nurse, the hospital, the discharge planners, that could be a nurse, a social worker, the hospitalist, PMR doctor. You've got, the SNF, the home health agency. You've got all these folks that are now trying to communicate with the patient and give them advice or tell them what they should be doing. And that's not necessarily resulting in the best outcome for the patient. It's like, I mean, if anybody has a subject matter you're interested in, you decide to Google it, I mean, how many times do you click down to page 20 after you've Googled it? I mean, you're inundated with a lot of information. It's hard to sort through that and get to the information that's most pertinent and most effective. Again, current staff versus new staff, what do you have currently that's going to roll into bundle payment? Do they have the skill set to manage the overall episode of care? Do you need to add new staff? Does that current staff need new training? Physician alignment, do you have a physician champion? Is a physician champion that other physicians respect and believe is going to be somebody that they're going to follow and listen to when he has these difficult conversations with them about changes in care pathways, or them not, a particular doctor not adhering to the overall arrangement that's been set up in the bundle. Are you setting up gain share, risk share arrangements? What do those look like? Do those actually provide enough incentive to keep the engagement there? And then your data sharing. I honestly am utterly surprised at the frequency where we hear that there's little to no transparency around data sharing, where there'll be information that's being shared with the physician and it's blinded, or it doesn't really get to the point. Our belief is full transparency and share data with physicians that they can impact. They don't need to be inundated with a bunch of data. They need to get the data that's actually impactful that they can have an effect on. Additional impacts, the last few things that are going to affect your organization in bundled payments, going to be your PAC network, setting up a preferred network, but then how do you guys deal with preferred and non-preferred providers? How much of your patient population is falling outside of your preferred network, and is it a geographic reason? Is it a care coordination reason? What is the reason? What's the reason for that, and how can you affect it? The preference, is it based? Is the current preference based on a physician, provider, or business or personal relationships? It's not uncommon for somebody to be, to have a particular relationship with a home health agency or a skilled nursing agency where a family member, a friend, or somebody like that works at, and that's really been the reason that so many patients are being directed at a particular provider. How are you setting up your scorecards with your SNFs, your home health, your PT, and so forth? Risk sharing, are you going to enter into risk sharing? How are you going to make those arrangements? Are those risk sharing arrangements ones in which those post-acute care providers can truly impact that cost and outcome? And then finally, the technology. Again, how are you doing your analytics? The claims data, the clinical data. Are you being able to analyze both of those things? Our experience was we worked with some organizations that had a lot of experience in bundled payments, very helpful for us initially, and then the organizations that we worked with that did not have really bundled payment experience really didn't provide a lot of value to us, either on the analytical side or the care management technology platform. So just a few things that I would say will impact your organization and have impacted us. And I'll turn it back over to Scott. Thank you.
Jim, thank you so much for that overview of the programs and that deep dive into your organization and how it's impacting you and how you're going about dealing with bundled payments and executing against that. We are receiving questions as they roll through, and we will plan to address them after we get to Diwen Chen, who will present to us next. So with that being said, we will jump to Diwen, and let me share a quick introduction of Diwen. Diwen is the Executive Director of Payment Innovation and Accountable Care at Dignity Health. She is responsible for system oversight of value-based payment initiatives such as bundled payments and accountable care. In her position, Diwen focuses on the creation of future-ready delivery models, leads cross-disciplinary teams to implement physician alignment initiatives, pilot payment reform, and expand care delivery across the care continuum. With that introduction, we're grateful to have Diwen with us to share her thoughts on what Dignity Health is doing in the bundled payment space. And Diwen, I'll pass it over to you.
Thank you, Scott, and thank you so much, Jim. Can everybody hear me?
Yes.
Okay, good. So thank you, Jim, actually, for doing the overview, because it'll save me some time, and let's just get kind of down into the weeds about what it means for our system to work in bundled payments. So Dignity Health, a lot of y'all are familiar with us probably by our campaign slogan, Hello Human Kindness. It's out there. And essentially, here's a profile. Let's go to the next slide. That's just a map of our footprint. We're primarily in California, Nevada, and Arizona in our acute hospitals, and then the rest of the footprint that y'all see was the acquisition of U.S. HealthWorks in their urgent care and occupational health clinics across the 17, 20 states that are on there. Next slide. Where are we going? When we look at Dignity Health and the footprint that we've got, we just really had a realization years ago in our 10-year plan and goals that we wanted to bridge the gap of where we were currently in a lot of silos, very hospital-centric, and we, at the time, were still under a fee-for-service payment model. So I think many of you could probably attest to this transition, if you will, of fee-for-service to fee-for-value. And if you go to the next slide, this is often the one that we show to all of our stakeholders. I often say that we're in this somewhat schizophrenic time period in our healthcare lives right now. The fee-for-service is, yes, it's on a decline. I mean, it's only a matter of time. We're switching our portfolio of our payer mix, and reform in payment models is certainly part of that. But what's challenging is if we've known something for so long and we just do it really, really well, whether that's operations, we know physician models really well, that crux, that center intersection, the meeting point of that is where I see our health system currently in place. So we've got everybody on a broad spectrum of philosophies and where they stand. So having to survive in a fee-for-service world, at the same time relinquishing a lot of control and trying to do something new in fee-for-value. Next slide. And so how do we get there? One of our broad examples, just like Jim was saying about the footprint of BPCI, was that we wanted to test the waters, if you will, for an active approach to healthcare reform. And at the time, this was 3 years ago now, so our longest standing two-hospital site that originated BPCI, this is their last year, or at least until CMS announces which way we go. But it is their 3rd year. And so we've learned a lot along the way. And, you know, I'll be the first to say that we definitely don't have it figured out at this point. I think what we have learned is a tremendous amount of knowledge getting us here and where we needed to be going forward. I think that's our opportunity, again, so third bullet here, to re-engineer and provide greater value. And so the big question of doing that is how. And of course, how do you do that is right for the patients? And how do you do that is right for not breaking the bank? And those are really quite, in certain contexts, juxtaposed because, you know, what some folks think that they're mutually exclusive, it's actually quite fitting, and there's a correlation between providing better value to patient care and delivering the right kinds of services at the right setting that will really have a financial impact that is positive. And so next slide. One of the value propositions for our stakeholders, and we kind of use this graphic to explain that, is that, you know, the value to physicians through participations in programs like bundles, CJR, and other types of models is that we gain access and opportunity that we have not had before to gain sharing waivers that really reward and try to align financially an incentive to care redesign. And improvements to quality that are then tied clinically back to what the outcomes are. Because I think that's huge, is that the quality measures, of course we set up so much infrastructure around quality and operations and the clinically integrated parts of our company. And of course they're challenging, but I think it's the right thing to do, and we all do. I think that's where we must figure out a way to provide value that does not lose sight of the quality and patient satisfaction aspect, because that is central to reducing waste. I don't think that, like I said, they're mutually exclusive. And so then when we look at care sites, and I call them care sites because we're really not just focused on our hospitals anymore. We're branching beyond the 4 walls of our hospitals to what is in our communities. What are the clinics that are there? What are the post-acute footprint and presence of the varying, you know, subacute, LTAC, IRF, you know, home health services, and what's provided at home or home care even, and what are those services that can continue to be leveraged and utilized in a very resourceful way to provide care for the patients outside of our hospitals. I think that's probably one of the bigger goals, and we'll share this later, the top 4 levers that we're working on now. But this post-acute space is something that, of course, we so often have not thought about because we had been hospital-centric, but in the last couple of years, I'll say the migration to that kind of mindset is really what's going to be impactful to our goals. And finally, you know, our value to patients is really why we're all here, because, you know, we firmly believe it's the right care, the right setting, the right service, the right, you know, amount of service, and what it takes for that are new staff members and a new mindset of training up new talent in this area of care coordination and patient navigators, and figuring out what kinds of credentials and degrees, what kinds of personalities, what kinds of talent, and it made recruiting all that much more fun for our HR folks to try to figure out who those folks are out there. But I think that's so huge, and you know, Jim had mentioned that there's new staff that they had too, and I think that's really a parallel for us too, because you really have to assess what and take inventory of what kinds of talents and resources you have available and figuring out what the gaps are there. Next slide. So now I know every time we see numbers on a page, we tend to get stuck on it, but this is more for illustrative purposes, and the numbers are going to change. These are from our initial reconciliation. Like I said, they're really meant to be a portrayal of some learnings that we did have. A few of them including this concept of simple pneumonia. So if you look at simple pneumonia, where we won quite a lot on positive NIPRA. But then conversely, if you look at CHF and COPD, we lost some on those, and particularly the COPD concept. So our takeaway from that is, what is the deep dive of who's taking care of the patients that have these episodes, and do they overlap? Are there root causes that are finding that story to be able to tell the markets, and then in which markets do we have this correlation of doing well, you know, in simple pneumonia, but also in the same breath doing not so well in COPD? You know, what are some of the pathways there? And a lot of it may just be a target price. You know, we are all subject to the same kinds of CMS true-ups, if you will, and that's why these numbers will change. But what we're after are looking at trends. And of course, you know, not one quarter does a trend make, but the more that we get data, the more that we see these claims populate our databases and try to make meaning out of it, that's where we're going to find the biggest impact to changing our operations. Next slide. So lessons learned, these are not anything different from what Jim had mentioned. I'm so glad that we can overemphasize this as lessons learned. So the magic formula is that it's care redesign. I mean, we really have to transfigure the way we've been thinking about how care has been delivered. And it's interesting that Jim and I had approached this quite similarly from the provider side, but maybe from two different approaches, one from a physician-centric side and one that historically had been hospital-centric. And I think that just goes to show that we are all in this together. Everybody's really after the same goals, so there really shouldn't be any reason to not work together on this. And particularly, this kind of mentality must come from executive leadership on down and adopted by the grassroots on up. And somewhere, like I always tell our team, somewhere we'll meet in the middle and it's going to get good. But, you know, until we get there, the emphasis about working in our communities, including physicians, post-acute, employers, and, you know, looking at community clinics, looking at what are the resources that are available, that's going to be key. One thing I did want to mention, so if you go on to the next slide, the reconciliation and true-up. So this is one of the interesting parts about gain sharing, and I'll speak to, is that so if you look at where performance periods are, our final true-up, having started majority of our hospitals last April 2015. So we're just under reconciliation now, but if you look at this timestamp, we're going to be looking at a final settlement with CMS October 2016. And we had a lot of sites that entered into gain sharing back in April. So I think this is just, like I said, it's more of an observation. We're certainly in full operations of gain sharing within many of our sites. I think the challenge that I'm speaking to is that the true-ups are looking at an 18 to 24-month initial delay for the payout if you're going to pay out on a final true-up. So I know the audience, I'm eager, and having looked at the attendee list, I'm eager to hear from all of you with questions and feedback and comments about how you all have handled gain sharing where you have participants in bundles, because this is really a crucial part of how we view an alignment between hospitals and physicians. And like I said, gain sharing is such a crux of all of that. It's why, you know, CMMI went after the OIG for those waivers, and we want to be able to utilize them in the best way that we can, and ones that bring value to our stakeholders. Next slide. And so that's it. I quite like this graph. It looks like it's a wide lens version of it. And what I often equate to is that we're mixing a whole bunch of what we know and our key operations, key strategy, relationships into a blender, and then out comes some version that we've, somehow figured it out specific to our system on how to control costs, how to improve quality, how to get down readmissions, how to tackle patient experience and make sure they're all there. And all of this, though, is that if you look at the levers that we have to pull for each of these payment models, they're essentially the same thing. And what it calls out is an entire transformation of our department, an entire strategy that may or may not have aligned with what we've known historically to be, here's operations, here's strategy, here's how we do finance. I remember one of our financial leaders had said, oh yeah, we're waiting on the top 4 accounting firms to publish, new accounting rules for how to book and book revenue and expenses to payment models like this. And I think that that's just key in how impactful these models are that have affected every single business line, operations line that we have. But it's the good news is that it's not compounded together. So if you look at the top, the payment models and bundles, CJR, ACOs, et cetera, are requiring to move the similar levers broadly, and then it's just nuance of how to make sure that these programs, don't overlap in the ways that are compliant and, legal and all those other aspects. But other than that, the levers that you have to push to be successful is the same across the board or very similar. Next slide. And so how do we get there? This is reiterating what Jim had already placed before you in his presentation, so I won't cover it in too much in depth, but I think you'll see here it's very evident that we are talking about a very long journey. Some of these, like some of our post-acute networks, have not always been keen on working in this space. A lot of it has to do with the financial incentives that they've got going on in their space, but also just the knowledge and empowerment that they need and resources that they need to be successful. I think a lot of them are turning around, most of them are turning around to intending to work with us and wanting, good intentions, and that's where we have to work together with our community to make this happen. So with that, I will end the presentation. Look forward to your comments and questions.
Thank you, Diwen. That was terrific. We really appreciate your insight into Dignity Health and how you're approaching the value economy and how you're approaching bundled payments as well. We'll jump into the Q&A section now. Again, please submit questions using the chat feature of the GoToMeeting window. We've had a few questions roll in, and I think this might apply to both Jim and Diwen. It relates to the PAC network. So let me have Stacy scroll up a bit. And what steps did you take to establish your preferred PAC network? And do you have one person who oversees the PAC network and keep it up to date? So about that PAC network, how do you establish that?
You want to go first, Diwen?
Sure. In short, we are looking at quality criteria. A lot of the Medicare star rankings are available, although we're not looking just at that piece of it. There's a profile, and I think we sent out a pretty robust survey that went to each of the markets to really gauge and have them send to us their quality. And we had a couple of measures that were standard across the board, if it's SNF specific or rehab specific, et cetera. And just assessing what community resources are out there. And we do have somebody that is dedicated not only at the system, but different roles that may play a part in owning the post-acute relationship. It's not as prevalent. I think we're just starting that, since last year. So I wouldn't say that, we're experts on fulfilling a preferred network of post-acute. But again, I think the caution is to make sure that if we're going down this route, make sure your counsel and your compliance folks are on board with you and working together, because there are just some implications that from a legal and compliance standpoint are important.
Yeah, this is Jim. I completely concur with that and agree with that. This is how we approach it and kind of have approaches. You get the claims data, and you kind of start with what you know. So you get the claims data, go through the claims data, look at where are all of the patients actually going. So, if we got a physician group in a city, okay, here's how many patients went to your SNF and went to SNFs and went to home health. Here's where they went. And so looking at that, okay, is that then is that driven by geography, and do you capture most of your patients within an hour to 2 hours of your site, or is it larger? Is it 6 hours? So you have a much larger geographic area to cover. And so how many SNFs are they going to? How many home health agencies are able to provide that coverage? Then we start breaking down into the, some of the things that we think are linked to the quality, because as Diwen said, and completely concur with her on this, is quality is the key driver of this. Don't make a decision based on cost. Make a decision based on quality, because high quality in care redesign is going to lead to lower costs. So we start looking at readmissions, and then if there's a high number of readmissions coming from a particular post-acute care provider, which we believe are avoidable, such as urinary tract infections, fever, things like that are other infections that are potentially facility-derived, we're going to look at those and make sure that those are, we understand which facilities are doing that and which ones are, and then put that into sort of our internal ratings. Then we look at the star ratings and the percentile ratings for home health and so forth, and kind of see where they lie on that. I would put one word of caution in on star ratings. Don't make the decision on the overall star rating. Look at all of the star ratings. So we have found that you might get a facility that's a 2-star facility overall, but they were actually a 5-star quality facility. And the reason they were 2 stars is that the reporting was not done correctly, so they got docked on that. So you want to look at all of these things in conjunction. Ultimately, then, you got to get face-to-face with these guys. You got to meet with each one of these skilled facilities, each one of these home health providers, and you got to talk to them. You got to get, this is a big program, so you need to look at it from 30,000 feet, but you also have to get granular and get down to the details. Same thing Diwen said about it's the grassroots folks that have got to also be engaged. So I'll give you a good example is, if you have, say, 4 doctors at a hospital, and 2 of those doctors are using Aquacel dressing on all their total hip patients, which is essentially microbial silver lining dressing, doesn't need to be changed. It's going to be put on in a sterile environment, doesn't need to be touched until that patient has a 2 to 3 week follow-up with a physician. As long as that dressing is not removed, there's almost 0 risk of infection for that patient. Suddenly you go and meet with a home health provider in a skilled nursing facility and say, hey, walk me through your protocols. What do you do when the patient comes over there? What's your standard nursing care? And they start walking through and saying the patient comes in, we assess their home, or we show them to the room they're staying in for their SNF. And suddenly you hear that the nurse says, well, and then we change their dressing. And it's like, wait, hold on a second. You change their dressing. It's like, yeah, that's the standard protocol we have here is we change dressing within X amount of hours after the patient's admitted or seen. So you want to make sure that your protocols, you don't just write them on paper. You got to make sure they actually get delivered. We have a team of people at Signature that oversee our post-acute care network across the country, because there's regional relationships, there's national relationships, there's ethnic, religious, and cultural impacts, so you're going to have to be very sensitive to those particular areas. You can't just go into a community and say, hey, at this one facility, I want you to hit these metrics and these numbers, and I want you to deliver this type of care. You still need to make sure those things actually align with the religious, cultural, and ethnic aspects that may be impacting that facility. Back to you, Scott.
Thanks, Jim. Thanks, Diwen. We appreciate your answers. Looks like we're hitting the top of the hour, and for that we won't be able to get to all of the rest of the questions. And what we will plan to do is help connect you with Jim and Diwen on the questions that you submitted. So we will plan to wrap up right now. Just a quick note about ACLC work groups. We're hoping to find out some information from you. So you've probably seen a few emails come from us, whether it be from ACLC or Levitt Partners. We're hoping to understand a little bit about your participation level in ACLC, as well as trying to schedule a first conference call and a first in-person meeting. So look for those communications coming through your email as time goes on. Again, yes.
This is Jim. I was going to say, if you want to send over any additional questions, I can write up an answer and send it to you to distribute.
Great, Jim. I will plan to send those questions over to you and get you in contact with those folks. Thank you.
No problem.
Same here, Scott. Everybody.
Thanks, Diwen. So we'd like to thank Jim and Diwen for their insights and perspectives today. This has been a very insightful webinar. An audio recording of this conference call will be made available and will be included in our weekly news summary. The next webinar will be on April 27th, with the topic being Strategies for Physician Engagement in Accountable Care. Our special guest will be announced later at a different time. So thank you very much for joining us, and we hope that you found this presentation valuable.